Hello, my name is Peter Voorhees. I'm a myeloma specialist at Levine Cancer Institute, Wake Forest University School of Medicine in Charlotte, North Carolina, and I'm going to be sharing with you data that we presented at this past December's annual American Society of Hematology meeting from the Kilimanjaro study, which looked at the combination of a novel BCMA bispecific antibody called Etentamig in combination with pomalidomide and dexamethasone, or Pomalyst as it's commonly known, for folks with relapsed or refractory multiple myeloma. So there are currently 3 FDA-approved bispecific antibodies that are available for folks with relapsed myeloma, including teclistamab, elranatamab, and linvoseltamab. Etentamig is another BCMA bispecific antibody, but there are several unique features about this particular antibody that make it very attractive for patient administration. First off, there are 2 binding sites on this particular antibody against the myeloma. So it attaches to 2 BCMA targets on the myeloma cell. So that leads to tighter binding of the antibody to the myeloma cell. It has a lower affinity or not as a strong interaction with the T cells, which potentially reduces the likelihood of some of the side effects that we see with bispecific antibodies, such as cytokine release syndrome. And then they've modified the tail of the antibody, which allows the antibody to persist longer in the patients after it's been administered. And what this translates into less frequent dosing, so less trips to the infusion center for receipt of therapy. There are 2 ongoing phase 1 studies that have been conducted looking at Etentamig by itself in patients with relapsed, refractory, heavily pretreated myeloma. And remarkably, the overall response rates have been 66%, so 2/3 of patients responding, which is quite nice, with a best-in-class cytokine release syndrome signal of only 30%, all of which was lower to moderate grade in severity. So the purposes of this presentation is to look at the safety and preliminary activity of Etentamig when given with Pomalyst and dexamethasone for patients with relapsed myeloma. Now, there were 2 different cohorts of patients that received the combination of Pomalyst, dexamethasone, and Etentamig in the study. There was Arm A and there was Arm E. Now, Arm A patients were more heavily pretreated, so they had to have relapsed at least 3 times or more in order to be allowed on the study, whereas Arm E patients could have relapsed 1, 2, or 3 times. So this is patients that are earlier in the course of their journey. For folks that were in Arm E, they could have had they were allowed to have been exposed to both proteasome inhibitors, immunomodulatory drugs, and CD38 antibodies, but they weren't required to be exposed to all 3 of those classes of drugs, whereas patients in Arm A were required to be triple class exposed to all of these 3 core pillars of myeloma therapeutics. Now, there were some differences in the way in which the drugs were administered together between Arm A and Arm E, and I think that this is important to recognize when we start to talk about the side effects of this combination. So the first cohort, Arm A, received full dose Etentamig right from the get-go, no step-up dosing of any kind, full dose right from the beginning, once every 4 weeks. And in addition, they received Pomalyst in the usual dose and schedule and weekly dexamethasone right from day 1. So all drugs given at full doses right from the beginning. We pivoted to what we thought would be a more patient-friendly way of administering this with Arm E as we gained experience with the combination. So in Arm E, patients just received the Etentamig bispecific antibody with cycle 1. Not only that, but we included a step-up dose of Etentamig, just 1 step-up dose. And the Pomalyst and dexamethasone was introduced into cycle 2. So we were hopeful that by doing this, we could mitigate some of the side effects that we were seeing in some of the patients that had received dosing per arm A of the study. So these are the baseline characteristics of the patients, both in arm A and arm E of this particular study. I'm going to focus more on those that were in arm A because a lot of the early efficacy data that I'm going to show you emanates from this group of patients. We have safety data from the arm E patients, but they haven't been followed long enough to really know what the ultimate overall response is going to be and how durable those responses are going to be. So again, focusing on the more heavily pretreated arm A patients, a third of them had stage 3 disease, and a third of them had high-risk chromosomal features associated with their disease. 50% of the patients were refractory to Pomalyst. So even though Pomalyst is part of this regimen, half of the patients that participated were refractory to Pomalyst. And you might ask yourself, well, why on earth would someone take Pomalyst with a bispecific antibody when they already have disease that's resistant to it? And the idea here is that while the Pomalyst may not have direct activity against the myeloma cells, it can actually, Pomalyst, as well as the other IMiD drugs like Revlimid, can actually stimulate T cell activation and potentially enhance the effectiveness of the bispecific antibody, even if it's lost its direct anti-myeloma activity. Now, importantly, approximately 3/4 of the patients had disease that was refractory to the 3 core pillars of therapeutics in myeloma, the proteasome inhibitors, the IMiD drugs, and the CD38 antibodies, and 100% essentially were exposed to those 3 core pillars of myeloma therapies. So when you look at cytokine release syndrome, this is the fevers and flu-like symptoms that can occur, with T cell redirecting therapies like bispecific antibodies. You can see in arm A where patients got the full dose of Etentamig and full dose Pomalyst right from day one. About a third of the patients had cytokine release syndrome, and most of this was grade 1. So we're talking about fevers and maybe some minor flu-like symptoms. 12% had grade 2, so perhaps some minor, fluctuations in blood pressure and what have you. But overall, a very favorable signal of cytokine release syndrome, particularly when you realize that we didn't use any step-up dosing and started the Pomalyst right out of the gates. So when we introduced them sequentially and added the step-up dose of Etentamig, you see that the cytokine release syndrome drops further to 23%. So approximately 1 out of every 4 patients experiencing cytokine release syndrome, the overwhelming majority of which is just grade 1, or the fevers, and again, mild flu-like symptoms. This is the best cytokine release syndrome signal that's been reported for any BCMA targeted bispecific antibody, and definitely lends itself to more easy administration completely on an outpatient basis right from the get-go. So when we look at side effects, and again, we can look at both arm A and arm E from a side effect perspective. And what's interesting to note, not surprisingly, as we see with any treatment that has Pomalyst in it, low neutrophil counts is a very common side effect. But interestingly, when we introduced the Etentamig first and then added the Pomalyst later, the severity of the drop in neutrophils seems to be less, which is very interesting. When you look at an infection perspective, it also looks like the infection signal is more favorable when we introduce them sequentially, although we have to be a little careful in how we interpret that results because the patients in arm E have not been followed as long as those in arm A, so they may not have had enough time to develop infections. Now, one of the other things that we saw that was a bit interesting, but thankfully not serious, for patients that were participating in arm A, is that there was some liver inflammation that we saw when we introduced everything at once at full dose. When we pivoted to the sequential approach with the step-up dosing, the numbers of patients who had some liver inflammation significantly dropped, and those that had more severe liver inflammation, there was much fewer experiencing that level of that particular side effect. And importantly, regardless of which arm the patients were in, the liver inflammation resolved. This was a very transient phenomenon that we saw in these patients. So this just digs down a little bit further into the low neutrophil issue that we saw with this particular regimen. So There were no unexpected surprises, as far as neutrophil drops, again, on a Pomalyst-based regimen. But importantly, there were very few discontinuations as a result of low neutrophil counts, and there was a very low rate of treatment discontinuation due to infection. So the low white blood cell count issue and the infection signal that we sometimes see with BCMA bispecific antibodies was a manageable problem, and in the vast majority of circumstances did not lead to patients having to come off of treatment. So when we look at effectiveness, and here we're looking at the Arm A patients, so these are the folks that had to have relapsed at least 3 times and be exposed to all of the 3 core pillars of myeloma therapeutics to be eligible. So the overall response rate was 82%, which is higher than what you would expect to see with Etentamig alone, or with any BCMA bispecific antibody alone for that matter, and realize that 50% of these patients had Pomalyst-resistant disease. So this is really a nice initial result in a heavily pretreated group of patients. Most of the patients that responded to therapy had either complete responses or what we call very good partial responses, which is really close to a complete response. So the majority of patients had quite deep responses to this therapy, which was really quite encouraging. Now, there are particular groups of patients that we know we've had a harder time treating. They might respond to therapy less well, or perhaps not respond to therapy as long as we would like. So we wanted to look at some of these higher risk groups of patients that were enrolled into the study. And again, we're looking at the RMA patients that were treated on the Kilimanjaro study. So if you look at overall response rate for those that had stage 1 or 2 disease going into treatment versus stage 3, very respectable overall response rate in the stage 3 patients. A little bit of a drop off from 86 to 71%, but a 71% response rate in a stage 3 patient population, is really quite respectable. When we see myeloma grow outside of bone or outside of bone marrow, we call that extramedullary myeloma, and that's a very difficult subset of patients to treat. And you can see here there's a drop-off in response for those that did have extramedullary myeloma, which we've seen with other bispecific antibodies as well. So those that did not have extramedullary myeloma had a 90% likelihood of responding to therapy. Those that had extramedullary myeloma had about a 47% likelihood of responding to treatment. Now, that's disappointing as far as the drop-off is concerned, but this overall response rate of 47% for a bispecific antibody is really quite encouraging, actually, compared to other experiences that have been reported thus far. And then when we look at cytogenetic risk or chromosomal alterations that would predict high-risk disease features, you can see that there's no difference in response rate between standard and high-risk patients. In fact, the high-risk patients, those that had high-risk chromosomal features, had an overall response rate of 80 or 84%, which is really quite nice. When we look at duration of response, so these are the patients that have responded to therapy, and we're looking to see how long they've responded to therapy. We haven't been able to follow these patients long enough to know what that median duration of response is, because when we look out to 24 and 30 months, there's still many patients that remain in remission, which is very encouraging. Progression-free survival is tracking those patients that are alive and free of progression or relapse of their disease. And you can see that this number looks really good thus far. And when you look out at about 2 years, approximately 60% of the patients still have not had progression of disease, which really looks quite encouraging for a bispecific antibody combination in this heavily pretreated group of patients. So just to kind of conclude, I think we're showing a very promising preliminary data with Etentamig in combination with pomalidomide and dexamethasone in heavily pretreated patients with multiple myeloma. I think that the safety profile of Etentamig is very consistent with what we've reported previously with Etentamig as a standalone therapy, and it's very favorable when we compare with other bispecific antibodies, particularly when it comes to cytokine release syndrome. And interestingly, when we introduce the step-up dose, and again, this is just one step-up dose, and the sequential introduction of the Pomalyst with cycle 2, the side effect profile really markedly improves, both respects to low blood counts, liver inflammation, and cytokine release syndrome. And we're very interested to see what the efficacy results will be in that Arm E group of patients who are less heavily pretreated. And you'll certainly see those results report out in the months ahead. So with that, thank you so much for your attention.